Hello, my name's Ian McCall. Let's have a little look at the interface and vacuolar reaction pattern. Now, we've spoken before about conditions that give rise to epidermal changes, and usually that ends up as a red scaly disease. But there are some, and the pathology there is either sclerosiform or spongiotic. But the interface reaction pattern can also give rise to epidermal damage. And if it gives enough damage, you'll either get blisters or crusts, or occasionally some aspects of scale. The main causes of epidermal changes that give a vacuolar reaction pattern are drugs causing erythema multiforme. And that's usually through the process of keratinocyte destruction. The drug binds to an antigen in the epidermis, and the immune reaction takes out both the drug and the cell that it's attached to, the keratinocyte that it's attached to. So keratinocytes are usually collateral damage. Now, the classic clinical presentation is as erythema multiforme. And this slide gives you an idea of what you'll see. You'll see the classic target lesions, where there's usually a central dark area and a lighter peripheral area. And they're regarded as iris or target lesions. These are particularly common in the lower legs, sometimes the palms of the hands and the soles of the feet. Occasionally, erythema multiforme will also involve the lips and other mucosal surfaces. And when it's really severe, it goes by the name of the Stevens-Johnson syndrome. Most cases of erythema multiforme are going to follow a herpes virus infection. Probably about 10 days later, bang, out comes the lesions of erythema multiforme. So let's have a little look at the histology. And histology is on this side, and this is an example here. Now what you see is the infiltrate is mainly perivascular. There is a bit of lichenoid infiltrate, but it's a sparse one. It's not like lichen planus. And when you look at the overlying epidermis here, you see that the lymphocytes are invading the epidermis here, causing damage to some of the basal cells and to some keratinocytes further up in the epidermis, because these are called Savat bodies. You can see the damage to keratinocytes here. And if you look further along this particular specimen, you can then see very significant damage in the in fact, the epidermis is almost gone here. It's almost necrotic. And that corresponds often to the damage in the center of one of these, the center of a target lesion in erythema multiforme, where here you've almost got full thickness necrosis of the epidermis. And that may separate and form a blister. Now, if there's some bleeding into it, it can be a hemorrhagic blister like this. You can see how tight the vascular infiltrate is around the vessels here, and some causing damage here. These are these dyskeratotic or Savat bodies that you'll see in erythema multiforme. Now, there are other conditions that can look like this histologically. I mean, graft-versus-host disease can look very much like this. Fixed drug reaction can look very much like this. And it's often difficult for the pathologist to separate these conditions out on the histopathology. These are a couple of other pictures of erythema multiforme. These are the sort of target lesions on the palms of the hands. There's one that's virtually necrotic in the back of the hands, corresponding almost to full thickness necrosis. These are target lesions on the legs as part of a drug reaction. I mean, sulfonamides will often cause this as well. This is a little schematic to show the indicated features. Now, if you get enough damage at the dermoepidermal junction, you'll sometimes get edema here, and you'll get a blister. You can see the thickened stratum corneum here. This indicates it's in the palms of the hands or the soles of the feet, and that's often where these target lesions are. The infiltrate T cells attacking the dermoepidermal junction there. And the keratinocyte necrosis can be both basal and suprabasal, as we showed in these areas up here. Blistering is more common in the Stevens-Johnson variant. So this is basal layer vacuolar damage. Interface pattern, and the classic lesion is erythema multiforme. We mentioned fixed drug eruption as a differential, histological differentiation of erythema multiforme. And we've said that it can, if there's enough damage from the drug at the dermo-epidermal junction, you can get a bolus reaction there as well. But when the fixed drug reactions heal, they tend to heal with a bit of post-inflammatory hyperpigmentation, and you get this melanin in melanophages in the papillary dermis. This is a good clinical picture of a fixed drug reaction. They're often annular like this. The degree of redness and whether there's a blister or not depends on the stage at which you see them. Each time the person gets exposed to the drug, and remember, it's not a drug they're taking all the time, it's a drug they're taking intermittently. The classics are the non-steroidal anti-inflammatories, but each time they get exposed to it, bang, the area flares up, same area as before. And then the erythema goes out and it leaves a sort of grey-black type pigmentation in the area afterwards, and that's the melanin and melanophages. So let's have a little look at the histology over here. And you can see a marked inflammatory infiltrate here. You can hardly see the epidermis here. There's so many lymphocytes going in and damaging it. Now you have to go out to here to sort of see any part of the epidermis at all, but look how the cells are all pink and significantly damaged. There's an exudate here on the surface. There's a lot of dyskeratotic cells here. Lots of lymphocytes. You can hardly see the dermo-epidermal junction from the lymphocytic infiltrate here. And lots of keratinocytic damage. Often you can get significant edema here, and that's when you'll get your blister. Look at the damage in that epidermis here. It's almost necrotic. Then you start to get back out to something resembling an epidermis here. If you look in the dermis, you may be able to pick up some melanin. Here it's here in melanophages. But this is because of damage to melanocytes, the dermo-epidermal junction, the melanin drops down. This becomes, this is an acute phase. In the more chronic phase, a lot of these lymphocytes would have gone and you would just see a lot of melanin in melanophages. But this is the fairly acute phase of a fixed drug reaction. This is another slide here that shows some of these features and has them highlighted for you. Papillary edema here can be a lot more than that. The necrotic keratinocytes that we spoke about, the marked basal layer damage here, you can hardly see it. This area here, this is the melanin and melanophages in the dermis. Look at all these pink necrotic keratinocytes here, Savat bodies. So it's a florid damage that you get from a fixed drug reaction. Interface, and not as much of a lichenoid infiltrate as you'd see in, say, Lichen planus, but still quite a florid lichenoid infiltrate. So that's how there's an overlap between lichenoid and interface vacuolar damage. This is an important little concept, the concept of the lesions having lives. In other words, when you biopsy something, it depends whether the lesion is just new or has been established for some time or in its very late phase. And what you'll see with a fixed drug reaction just depends on the phase at which you do the biopsy. And if clinically you've got lesions in different phases of development, biopsy different ones. Give the pathologist a chance to see them all. Just goes over the prominent interface damage, the Savat bodies are dyskeratotic cells. In erythema multiforme, the epidermal cell death can occur at all levels, often a marked infiltrate of lymphocytes. In fixed drug reaction, a lot of the damage, well, it really can look like erythema multiforme as well. What were we commenting on here? That it's a type 2 immune reaction. In If you get complete necrosis of the epidermis, then they call it toxic epidermal necrolysis, and that's a very rare condition, usually in someone taking anti-epileptic drugs or, again, non-steroidals, and often within the first month or so of them starting on those drugs. And unfortunately, the immune attack causes complete destruction of the epidermis. The skin is red all over, tender. When you put your hand in it and move, the whole skin just sloughs at the dermo-epidermal junction. And this was an example, I think, here of toxic epidermal necrolysis. You can see the separation here and virtually the full thickness damage to the cells in the epidermis. Not much of an infiltrate. See how the infiltrate isn't marked? It's often a relatively cell-poor infiltrate in toxic epidermal necrolysis. These are some clinical examples from Global Skin Atlas. We might just look at this one. It gives you an idea. Look at the redness, look at the sloughing, the peeling of the skin. And this is full thickness epidermal necrosis. And this is why these patients have to be managed in a burns unit when they occur. This picture here just shows you the severe mucosal damage and eye damage that you can get in this. And this is just another clinical. Look at the extent of the epidermal necrosis and toxic epidermal necrolysis. It's really not a condition that you want to see. So we've had erythema multiforme, we've had a fixed drug eruption, toxic epidermal necrolysis. The third one is graft-versus-host disease that can give that interface reaction pattern. This is usually seen in people who have had bone marrow transplants, and the donor bone marrow attacks their skin in the acute situation, and they can get, sometimes a lichen planus-like rash that they can in fact get. But the histology is really significant damage at the dermoepidermal junction. These are some pictures of it here that we might just have a little look at. Again, these cytod bodies that we spoke about before, again, damage at the dermoepidermal junction. Not a fairly sparse lymphocytic infiltrate here. Often lymphocytes will go into the epidermis, and you'll see what's called satellite cell necrosis. And this is where you've got a pair of lymphocytes either side of a keratinocyte, and they're killing the keratinocyte. Acute GVH also involves the follicular infundibulum. It'll go down the opening of a hair follicle as well. And the big difference is in chronic graft-versus-host, this gives a sclerodermoid picture with thick dermal collagen. So it's totally, and there's not a lot happening at the dermoepidermal junction. So let me just see if we can get some pictures of acute graft-versus-host disease for you. These are some examples here of graft-versus-host disease. You can see it's usually a red, non-scaly rash. You have a case down here, though, that's a lot more acute. And, if you look at this, if we can bring it up, you can see the extent of the skin necrosis here. Now, that's really acute graft-versus-host disease. You can imagine the amount of epidermal keratinocyte damage that's occurring. It's almost like toxic epidermal necrolysis in that situation. If we look down, often changes in the palms of the hands as well. So you look at it and you're perhaps looking for target lesions in erythema multiforme, but you tend to get a palmar erythema, acute palmar erythema like this. Again, it can peel depending on the level of damage that you get to the epidermis. Here's another example here. Red and scaly, a little bit more purple, perhaps a little bit more lichenoid-like, but, it's not classic lichen planus. Usually it's a generalized erythema, maculopapular, some areas having a lichenoid look to it, occasionally a bit of blistering depending on the severity of it. And with chronic GVH, that's when you tend to get the hyperpigmentation, the sclerosis and the like as well. But the acute one, the histology is very similar to fixed drug, very similar to erythema multiforme. The other condition that you have to consider is lupus erythematosus. Not so much the chronic discoid lupus, which gives very much a lichenoid infiltrate, but more subacute lupus and systemic lupus, and especially bullous lupus. They tend to give an interface pattern with a lighter infiltrate at the dermo-epidermal junction and give significant damage to the overlying epidermis. In discoid lupus, the damage is usually around the follicles and damage to the basal layer melanocytes as well, giving some of the hypopigmentation afterwards that you see. And also you've got follicular plugging. But subacute lupus is where you're going to have more of this basal vacuolar damage. Now, this is a clinical example of subacute lupus here, where you have a red non-scaly rash on the front of the chest over the shoulders. And if you were to look at the histology of it, it would be somewhat like this. That this is actually, the histology here is a bullous lupus. You can see, well, two things to see. A superficial and deep lymphocytic infiltrate. And the lymphocytic infiltrate will involve adnexal structures like the eccrine glands here, like the pilosebaceous gland. You'll see the lymphocytic infiltrate around about that. So when you see a superficial and deep perivascular and periadnexal lymphocytic infiltrate, go up and look at the dermo-epidermal junction. Now, you can see there really isn't a lot of lymphocytes that are like here, but there's significant damage to that epidermis. So much damage that it's splitting here, and this is forming a blister. So this is the histology of bullous lupus. Subacute lupus would give more damage along the dermo-epidermal junction without that blister formation, and still give the superficial and deep perivascular and the lymphocytic infiltrate around the adnexal structures as well. These are some other pictures here. This was more the picture that you would see in a discoid lupus picture. There's that follicular plugging that we were talking about. There's more a lichenoid lymphocytic infiltrate. You can see, you can hardly see the dermo-epidermal junction. There's a lot of damage occurring there. There is a superficial and deep one. That's the other little feature that you'll often see, that bluey color in between the collagen bundles here is mucin. Subacute probably has more of it than discoid, although there's a variant of discoid called tumid lupus that has a lot of mucin in between the collagen bundles. There's also mucin in systemic lupus as well. So pathologists usually stain for mucin. It helps them to, say, distinguish dermatomyositis from lupus. There's more mucin in lupus than there is in dermatomyositis, but the other histologies can be the same. So if we go back and have a little look at the other histologies here, this is subacute lupus, again a lighter lichenoid infiltrator interface, areas of interface damage at the dermo-epidermal junction, and a bit of the infiltrate round about a follicle. And if we look down, we don't have one of systemic lupus. The thing about subacute lupus, by the way, is that they're usually ANA positive and Rho antibody positive as well. And that's the Rho antibody that gives rise to the photosensitivity. It's also the Rho antibody that crosses the placenta in pregnant women and can ultimately give rise to neonatal lupus with damage to the conducting system of the heart as well. So, subacute lupus can again be a diagnosis you have to consider when you've got interface damage. And Rarely, lupus can in fact go down into the fat and involve the fat as well. It's usually a lobular paniculitis that you'll get. This was bullous lupus that we talked about, which was this example here with the subepidermal blister. Commenting often some neutrophils in the dermal papillae in this, but lymphocytes in the perivascular area. But really, bullous lupus is rare. We mentioned dermatomyositis there. It's a condition that is characterized by peri-orbital edema like this, often with a violaceous hue, a degree of photosensitivity as well. Changes on the nails, marked periungual erythema, and of course they usually have some degree of muscle weakness. They usually also have what's called the Scholl sign, erythema over the upper back as well. And sometimes it's that's biopsied. That sort of biopsy may just show a picture that's very similar to a subacute lupus, as this particular example shows, where really you've got a fairly nondescript infiltrate, little bit of interface damage, not a lot of dyskeratotic cells as in some of the others, and only a superficial perivascular infiltrate, not a superficial and deep. And if you stain for mucin, there isn't much mucin here. But it can be very difficult, to make a diagnosis of dermatomyositis just from that picture that you're seeing there. The basal damage is relatively mild. There's really no mucin in the dermis. You can say that's compatible with dermatomyositis. That's about all. So not as, obviously, interface damage isn't as florid as that interface damage you were getting in erythema multiforme, fixed drug, or bullous, toxic epidermal necrolysis as well, graft-versus-host. They're the ones that give you the really marked infiltrate and damage. The only other condition that can show a sort of mild lymphocytic infiltrate at the dermoepidermal junction, with basal vacuolar damage, is lichen sclerosus. Now, lichen sclerosus, I don't think we've got any pictures there. Let me show you some pictures of it first. There are two types of lichen sclerosus. There's the extragenital variant, which is what you're seeing here, and there's the genital variant. Now, in most cases we're going to see clinically are going to be the genital ones, but you may get both biopsied. Let's just have a look at this particular picture here. So, it looks like there's a little bit of surface scale here, but you can see the sort of white color, occasionally a little bit of purple around the outside here, indicating some inflammation. The white is primarily due to collagen being laid down in the dermis. We'll just have a quick look at one or two of the other pictures. This is on the abdominal wall. You see it's almost fine wrinkling cigarette paper changes in the surface here, that little bit of erythema, purplish erythema around where the lesion is. Morphea can look like this as well, but it's not as firm. Morphea is much firmer than, say, lichen sclerosus is. And occasionally this will come up as a little blister if there's enough damage at the dermoepidermal junction. Now the other variants of this condition, that's one on the breast. Again, it shows perhaps the thickening of collagen under the surface much more here, but there's a little bit of bleeding in between where the dermis and the epidermis are separated here. It's been a little bit of hemorrhage in that area here. But classically, it's usually at the genitals. So let's have a quick look in here for that. Which one will show it best? Yeah. That's genital lichen sclerosus. The inflammation is occurring on the prepuce here, on the undersurface, and it's causing constriction. This is as far back as he can withdraw his foreskin here because of that collagen that's laid down. And this is known as balanitis erotica obliterans, but it's a form of lichen sclerosus. Now, this is the histology over here. And this is we talked of the lice of lesions before. This is a fairly chronic one. There doesn't appear to be much happening at the dermo-epidermal junction, but look at all this collagen laid down here. So you've got this thick band of collagen, and then you've got your lymphocytic infiltrate in this area here. It's a very sparse one too. Now, I'm sure we've got a couple of other examples of lichen sclerosus. This is what causes that white color that you're seeing. Let me see if I can get some other histopathology for you. This is another one with a relatively mild lymphocytic infiltrate here. Bit of collagen laid down, some damage occurring at the dermo-epidermal junction here. A little bit of pigment there. This keratotic cell. Subtle though. Then you come along here and there's a bit more damage, and this is where separation is occurring. And this would be the imminent blister formation because of lichen sclerosus. Let's see if we can get another case. This one's again showing, there's the epidermis here. This one's showing a bit of blistering here. There's all that thick collagen that we were looking at. And there's that lymphocytic infiltrate deeper down in the dermis with that overlying thick layer of collagen. I mean, this again is a chronic stage where separation and blistering is occurring. There might have been some bleeding in here showing that hemorrhagic change that we showed in the one before. But it's a very distinctive pattern. Usually, it's very different to, obviously, erythema multiforme, graft-versus-host fixed trunk. So you really should be able to pick up bullous lichen sclerosus quite easily. As a summary, again, this was what we had on the website here. A thinned epidermis, the blister occurring here, the thick layer of collagen, and any lymphocytic infiltrate you have is underneath that thick collagen here. We call it thick homogenized collagen, a subepidermal bulla here. Bit of bleeding, larger vessels underneath here. So this is lichen sclerosus. So just to refresh again, major changes, major histological conditions showing an interface reaction pattern are erythema multiforme, Stevens-Johnson toxic epidermal necrolysis, the fixed drug reaction pattern, the graft-versus-host disease, the acute type of graft-versus-host disease. A lot of cytoid bodies in that, just as there are a lot of cytoid bodies, dyskeratotic cells in erythema multiforme. Lupus, the different types, chronic, discoid with a more lichenoid picture, subacute lupus with the more interface damaged picture. Similarly with systemic lupus. That was just lupus paniculitis being a lobular paniculitis. And dermatomyositis, again, a mild lymphocytic infiltrate here, mild lichenoid infiltrate, mild basal vacuolar damage changes, no mucin in dermatomyositis, and the thick layer of collagen that you're going to see in the dermis in lichen sclerosus. Thanks very much.